Okay, so we're going to have the 4 report outs now. Each reporter just has 3 minutes to do this. So please try to be succinct, and we'll interrupt you if you're running over. If you want comments or questions during the report outs, send them into the messaging chat room, and we'll try to cover them. So I think we can go ahead. And then, of course, when we're done with these 4, we've got a break. So I don't know who wants to go first. Any volunteers of the 4 report outs?
Stephen, Natalie Ratelli was kind enough to volunteer for our group. We had a terrific conversation, and Natalie, I'll hand over to you. Thank you for doing this.
Perfect.
I feel like I got voluntold on that bad boy, but I'm happy.
I see nothing.
You're welcome. I was trying to organize thoughts because I was just writing down literally the words people are saying, but I think we have some great thoughts around making trials more people-centric. We had some main topics around improving representation and relevance. We only got there, but actually our comments also tied to community engagement, demonstrating trustworthiness, and engaging a more diverse workforce. So some things we heard are that we have to think about metrics. No one ever wants to talk about that, but we have to think about if we improve representation and relevance, how are we going to capture that there is actual improvement? You can have a lot of activities and hope that they work, but we have to be able to capture that. And we talked about representation and relevance to people when you have such a small set of people actually engaging in the clinical trials. Is there thought about making the clinical trials larger? I know from pharma that can be, there's a lot of considerations there, but also obviously the representation of people so that it is relevant for others. We talked about how relevance goes both ways. Obviously, you want the output and the trial, the results of your trial to be relevant to the people, but you also want the clinical trial participants to feel appreciated and relevant as well. We talked some about medical school, about physicians, and that's sort of the representation of the PIs. We had someone from the National Medical Association. I was so grateful she was there, talking about some of the efforts they do there. I happen to know there's like a women's medical association also having a track to learn about being investigators. So we would like to increase diversity in PIs and probably site staff. We have to think about how few people of color are in that area now and what we can do for that. And our academic centers set up for that to be an advantage. There's so much med students and physicians are doing, it's hard to make time for that. So we have to think through that. And then if there are PIs that are new and minorities, are people going to them if they're not attached to a larger organization? Someone made a great comment about there are some things that we feel less in control of about the PIs and some things that we can do, obviously. We can identify best practices. We can look at our study design and see if there's anything, inclusion, exclusion criteria, visit schedule that is making it harder for minorities to be included. Someone at Duke mentioned that they have an easy access site, which probably has longer hours. You don't have to set an exact time. You can come in and the staff reflects the community, which I think is really important. We talked about how we need to train the family physicians or the physicians that you're talking about disease with to explain the clinical trial, the next step of a possible clinical trial. That's where we need to get to the people versus sometimes the PIs, they're not there to talk to the people as they learn about their disease. We talked more about trustworthiness. I don't know where I am with our time.
We're probably out of time, so close up. I mean, one more point is fine.
Okay, there's so much there. I do think as I work in pharma, they talk about acknowledging the past. I think that's really important. I've never seen an apology made where you just say, let's just do better in the future without talking about what has happened. That's a big component of it. That's probably just from me, not from the group. That's a disclaimer.
Okay.
Thank you so much.
Great. Thanks very much, Natalie. Next, Mark, do you want to go next? Great.
Yeah, and I'll go and I'll cover issues that haven't already been brought up. I think for us, the overarching themes were trust, community, efficacy, partnership and metrics. I would say in general, at first glance, there seems to be a conflict between efficiency and community building. There was a highlighting of the importance of partnerships and having established partnerships when trying to reach particular communities. These patient partnerships are in particular viewed as important, and there was a call for, pharma using patients as communicators and advocates. There is also an issue brought up around CROs maybe being a dated model or maybe not being guided in a particular way towards inclusivity by industry partners. There was an issue brought up about how the clinical trial enterprise is piecework and how it's hard to have a sustainable impact in communities when you're just going from trial to trial, and that perhaps we need to have a sustained investment in building communities and maintaining trust. Another point was raised that in a lot of cases, regardless of trust, certain communities just are not approached to participate in trials because there's assumptions made about adherence, and that perhaps those groups, there could be a focus in recruiting these groups that haven't had participation in trials. There was also a thoughtful comment about making the approaches used in CBPR normative and considering a community scientist as part of the research team, and that clinical trials really need to reflect the epidemiology of the underlying disease. There was a comment on having sort of technology and delivery integrating multiple stakeholders. And then sort of lastly, sort of a recognition of how, at least on a superficial level, finances kind of push in the opposite direction of going to communicate particular communities because you just are focused on the most expeditious way and going to sort of known sites. And then lastly, we kind of closed with looking at granular goals, such as establishing principles for inclusion, considering public-private partnerships for sustainable community relationships and networks. There was talk about having the service be a motivation for doing this science, and aligning of incentives such as patent exclusivity as a motivation to include communities.
Good. Thank you, Mark. Who's next?
I'll have our group go next. They were very self-directed, and Jonathan Watanabe is going to be our rapporteur.
Okay, thanks, Pam. Thanks, Jonathan.
Thank you.
Thanks, Mark.
Thank you, Pam and Stephen. I'll try to say things that were not already said, but there were certainly similar themes. So one that we discussed was how do we just, in terms of what we would add, it would be to add access in terms of representation and relevance. So also the means of finding new methods, new approaches, digital or what have you, to improve access to clinical trials to make sure that we've got better representation. There was also a great comment about making sure that we do not overgeneralize of any subpopulations or minority groups that we're interested in reaching out to. That certainly there was many that fall outside kind of the general stereotypes, and that we need to be sensitive to that if we really want to make meaningful change. Looking at expanding the clinical research infrastructure, which I think has been said, extending beyond the traditional research institutions. So how do we engage investigators that typically don't participate in this? So quote, naive investigators to do something different so we get that representation and also get that scale in terms of that might make it more pragmatic to get more rapid accrual. Let's see. Investing in diverse investigators and sites that serve diverse patients could be one of the actions we certainly would recommend, including support for sites and patients. In terms of the short-term actions, some of the things we mentioned were investment in the community, so building research infrastructure where they are, investing in diverse PIs, again, within that communication or community. Things that could be quick actions is reaching out to some of the schools outside of the typical main centers that we use to build that pipeline. We commented that many lessons that we learned from COVID that we could apply. How do we use our funds to leverage the skills of the community? So we talked a lot about investment in the short term to eventually get better results in the long term. Other long-term goals that would just take time, but it's how do we better partner? So the conversation kind of ended with how do we use particularly the pharmacies that are already there in the communities? How do we, there's some scale there, but just setting up effectively the strat plan to make sure that we can better leverage infrastructure that already exists, but perhaps not as well tuned as it needs to be. I think that's the main highlights.
Great. Thank you, Jonathan. Who's next? Who's last?
So Jean, with the skip bars.
Can you hear me?
We can,
Yes.
perfect.
Great. It might help to unmute. So just to add a couple of things that our group, which was very lively, said, and I'll invite them to add to anything that I'm going to comment on representing our group. So we talked a lot about leaders and stakeholders in healthcare needing to be represented in the workforce around clinical trials. We also talked about the importance of defining what patient-centered research for racial and ethnic minority populations look like. What should I, as a stakeholder, be doing, and what should be done? We talked a lot about implicit bias training, diversity and inclusion training must be included and designed for all stakeholders throughout the process. We talked about good clinical practice should include representativeness broadly. We talked about the importance of ensuring pediatric and rare diseases are important to remember to include as part of our work with respect to representativeness. A lot of times the discussion and the focus is around major high prevalence diseases, and we tend to maybe leave out pediatrics and rare diseases. Important to be inclusive in terms of our finding and recommendations. Really define what trusted community engagement looks like for research, the people, the process, the technology. One thing I'm going to add that we didn't talk about is make sure that trials and research are placed where the patients are. Seems like a trite thing to say, but we should encourage the use of prevalence data because every disease has a footprint. And sometimes placement of trials are not placed where racial and ethnic minority populations are located. So we need to do a better job of planning with respect to placement of trials. So it doesn't take 100 miles round trip and a hotel room to include patients in a clinical trial. With respect to milestones, we talked about how we should measure success. So this should be driven by what is meaningful to communities and driven by what their long-term interests are, not what we think the metrics should be. So what is meaningful to communities, that must be the basis of how it is that we measure success in the short term and the long term. We should measure trial complexity and we should require reporting outcomes that communities want. And we also talked about collection and reporting of racial and ethnic minority data with transparency, and there needs to be consistency in terms of what is captured by the major journal, which submitted, and also what's captured by major journals where data is submitted. So hopefully those are additive comments to some of the good comments that have already been made.
Good, thank you. Jeff Drazen, were you trying to say something? You were just being social. I saw him waving. Okay, so that's our 4 breakout groups. It sounds like a lot of productive suggestions that were made. We now have a 30-minute break. So we'll reconvene at 12:45 Eastern time. Esther, any last minute points before we break up?
No, this was great. Thank you so much.
All righty. Thanks, folks.